Okay, I know there's a limited time allocated to the meeting, so it's probably reasonable to make a start. Dr. Farden, I think, is still off. He appears to have the most amazing following for his emails of any I've ever seen. As there's folk who've never been to Grand Rounds appear to be completely up to date with his emails, so I hope he'll be back in charge of these soon. My name's David Finlay. I'm currently locuming in old age psychiatry in the Kingsway Care Centre. I'm hopeful that a brief discussion of some aspects of assessing mental capacity could lead to small, perhaps mutual changes that could be useful. I would exonerate from any of my comments my colleagues Ziad Tayar, who's now doing the liaison into Ninewells in conjunction with Sandra Robertson, Anne Harland and Claire Loftus, as well as Andy Shewan, currently the dementia nurse consultant with whom I used to do the old age psychiatry liaison into Ninewells some years ago, and Cesar Rodriguez, who continues to try to take forward the overall issue of mental capacity in the general hospital setting. I don't think I have any conflicts of interest. I may have a vested interest in trying to take the number of potentially inappropriate referrals down, but I hope there's nothing worse than that. There is, as you know, a legal presumption of competence, which is the word used in most of the rest of the world, but in Scotland it's capacity for both clinical and legal. But I wanted just to remind us we're in a broader context. I'll touch briefly on consent to treatment, but there are many within this establishment much better versed in that than I am, and those who were here last week for Matt Lambert's excellent talk will know that he dealt with some of the aspects of that. Even in very acute situations, he emphasised the importance of proper consent and thinking forward in terms of capacity. I want to briefly introduce a notion of professional doubt, which I think sometimes could usefully replace referral. Touch obviously on the overall assessment language in respect to mental capacity, and touch again on the general authority to treat, mainly manifested in section 47s. I have a Fitbit rather than a watch, so if I'm wandering past the time, please tell me. In terms of capacity, it is, I believe correctly, generally focused on a specific decision at the time it needs to be made. That fits well for isolated incidents. It's a more difficult model for day-to-day treatment and care. In terms of consent, information is increasingly prescribed, and there are now new standards for levels of information in terms of certainly surgical interventions. And people often forget the importance of at least considering facility, at least considering that the person is making a free choice. I'm sure we've all encountered so-called difficult relatives, but I fear that the people most likely to exert an unknowing influence on somebody's choice are actually the staff with the best of intentions. So the Adults with Incapacity Scotland Act was the first major piece of legislation of the new Scottish Government way back in 2000. The part that pertains mainly in the general hospital setting is Part 5 relating to medical treatment. The manifestation of that is a Section 47 certificate, which can be used almost in isolation for single episodes of care, but that, I think, is quite unusual and perhaps not ideal. You can fill in one line on the certificate, and that would be legally sufficient as long as the line covered everything that the patient was likely to encounter. But I think it's probably best practice to use the associated treatment plan. Apologies, this will not project as well as it might have done. It's only there to show one possible approach that we attempted to develop in Dundee some years ago and then exported around the country to some extent, it would be worth mentioning it's not the currently favoured approach. The current approach is to encompass the certificate, a flowchart, and some very helpful wording advice in a 4-page document, and Andy and Cesar are currently promulgating that. The idea of this one is to try to compromise between single instances of care and overall approaches, and to assess them all individually and suggest whether the person is capable or incapable in relation to them. So, I mean, it's a long way away from the thousands of decisions we each make every day, but at least it's looking at a dozen possibilities rather than just one or two. And the bottom item is a catch-all which can be used, if you like, to customise the document. There's a difficult concept attendant with incapacity that this possibly helps to avoid, is that once you say somebody is incapable in some respects, you have to watch that people don't then, however innocently, reverse the presumption. Clearly, if you're incapable of some things, it behoves us all to consider whether somebody may be incapable of others, but it doesn't remove the legal presumption of capacity. So you're working, if you like, under some sort of double presumption. The general questions. The biggest bugbear is getting asked to assess capacity, quote unquote, without any guide as to what it's for, when it's for, why it's for, who wants it or needs it. The biggest difficulty for all of us is the point at which to pitch the assessment of capacity. How much does somebody really need to understand? And sadly, neither the law nor professional guidance gives us as much help with regard to that as perhaps we could do with. So there are ethical issues, if you like, in the sense that if you choose to pitch the question at a fairly low level and make it quite an easy decision, the person remains capable. And if you decide to pitch it at a murderously difficult level, the person may well become incapable. And really the only protection they have against that is us doing our level best to pursue a fair balance between autonomy and safety. And ideally, discussions about capacity would be in relation to very precise requests. This was my own wording to try to get across what I think should happen. It is not popular among social work colleagues, and it can infuriate GPs, so it's not off to a good start. The more formal version, from guidance given by the BMA and the Law Society, is not so different, however. They would suggest that the person who wishes to make a decision on behalf of another who lacks capacity is responsible for assessing that person's capacity. That carries, as best I've been able to establish, as far as any of us who hold powers of attorney. In respect of the person for whom we hold a power of attorney, we are responsible not only for acting in that person's best interests and following other principles when we make a decision for them, we are also responsible for deciding whether we should make the decision or not, or whether they're still able to make it, despite the existence of the power of attorney. Even, I think, a welfare guardianship, in which the chances are the person is significantly more impaired, should still follow these general rules. The principles, known throughout the world, I think it's fair to say admired throughout the world, and the type of legislation follows in the sense of this is what's called principled legislation. All disputes, all uncertainties are meant to be resolved by going back to the wording of the principles, not so much by legal precedent, though legal precedent clearly comes to have its place in terms of shortcutting decisions and avoiding huge debates on basically the same issue. But in theory, a difficulty should be addressed by reference always to these guiding principles. There are other associated issues such as advanced statements, where you're trying to incorporate what the person may have said in the past. There's national guidance in regard to advanced care planning. There's what's called a getting to know me document in terms of, hopefully, developing some sense of the individual's preferences. And there's the really difficult one of how do we in practice support the residual skills of a patient. I think with regard to dementia, which is obviously what old age psychiatry has a lot to do with, that is quite problematic. Perhaps in learning disability over someone's lifetime, it's a more realistic proposition, but it remains incumbent on all of us to try. By contrast, our definition of incapacity has not fared so well. It is almost unique in world terms, and it has given rise to some difficulties in terms of how you interpret acting, how you assess someone's liability to act on a decision. Retaining memory of a decision is difficult to quantify. The Mental Welfare Commission have issued some guidance which is helpful, but it's still hard to know whether it's recognising your own written commitment or whether it's coming to the same decision when given the same information and process. And you'll notice here the word decision crops up 4 times. The decision probably isn't the crucial bit, it's the decision-making process. So, as I say, principles utterly well recognised and established. In real life, even now in written guidance, I see a much greater tendency for people to move towards the principles of the Mental Capacity Act in England, which is much more in line with world jurisdictions. Again, this is simply suggesting that you cannot be deemed legally incapable unless you have a mental disorder or a physical disorder of communication. In clinical practice, I think it's easier to think, can I actually assess this person? Because if the answer is no, you can't make a decision on their capacity. You may well want to go to a speech and language therapy colleague to say, can anybody communicate with this person? But it's important to be able to communicate enough to make the assessment. If you can do that, I suspect it would be unlikely that capacity would then founder on the person being unable to express their choice. So I think there's a slight problem around communication. Certainly in terms of the potential input of old age psychiatry, I would see that as being in those cases in which mental disorder is suspected, but where confirmation is required, and that is wholly legitimate. This wording I would commend to you. I believe this draws together a lot of what is important. There has to be understanding. There has to be understanding both about the what and the why. We speak of benefit, which is totally reasonable, but I think it's possibly better to speak of net benefit, having considered risks as well. It's great if the adult, the patient, can spontaneously generate the options and alternatives. That makes you feel a lot happier about their abilities. But even if they can't, if they can deal sensibly with the ones generated for them, that again is reassuring in terms of their capacity. What is sometimes missing is also information to them that the multidisciplinary team has actually made a recommendation, does actually have a preference in terms of what it wants them to do. That doesn't force them to do it, but it's important for them to know whether they're being given a recommendation or simply being given options to consider. And this idea of retaining information long enough to wait, what's called use it and weigh it in the balance, which is slightly legalistic language, but I think reasonable. You have to do more than just carry the information with you. You have to actually be able to work with it. And to do that, you have to be able to recall it from the start of the discussion. I believe that's a useful concept, rather than the one of retaining the memory of the decision once made. I think, as we discussed in respect of consent, the relevance and adequacy of information is absolutely crucial. I think the definition and the complexity level of the task remains at almost an ethical level for deciding. We can only do our best. There is more guidance available for some types of decisions than others, but very little guidance is at the same level of complexity as the clinical scenarios we encounter day by day. So there are always assumptions, there are always ethical considerations, in my opinion. It's not always clear when someone is seeking an assessment of capacity rather than carrying one out, who even controls the parameters of information, who even sets the level. I'm not sure that you can do an assessment without having some input to these things, but in theory, the person seeking the decision is the one in control of the process, so that could give rise to difficulty as well. My feeling is, it's almost another lecture, but my feeling is that assumptions, however regrettable, are almost always necessary. There's usually something missing when you come to do an assessment and you're having to make an assumption to fill in the gap. So the notion of professional doubt, I would suggest to you, is where anyone from a High Court judge to a carer going in to deliver hands-on care in someone's house has a sense that something isn't quite right. The carer perhaps is denied the opportunity to do the job they've gone to do, and they have to decide, to some extent, whether they simply accept that that's reasonable, the person no longer needs it, decide the person's in a bad mood that day and they'll be okay tomorrow, or no, they are not actually getting it, they're not quite grasping the implications of this, and then they have to go back and talk to their boss, their supervisor, who may well talk to somebody else, and gradually wheels would kick into motion. But my contention is that that person is expressing what I would call professional doubt and almost doing a mini capacity assessment. It's not one that will have any legal standing, it won't be signed for, but they're coming and saying, look, I don't think they really understand that turning down the care is going to be bad for them, as opposed to they don't want it anymore, we'll stop. In hospital, we look a lot at authority for continuous care. Ideally, decisions, to my mind, should be part of an overall multidisciplinary process, just as the care itself is part of a multidisciplinary process. Again, there's this notion of the incapacity threshold. Again, a very imperfect process, but hopefully one better delivered by a team than by an individual. That's how much capacity is retained, how much capacity is lost, what can we push on the person's behalf, what must we simply listen to them and take them. Paternalism is a word used relatively recently and once or twice in English court cases about a particular profession. Anyone give me a guess? Doctors? Doctors are apparently paternalistic. We are paternalistic. We think we know best and the person should simply do what we think. I find that perfectly reasonable, but it's not, in law, as simple as that. Risk aversion is used about another profession who sometimes tell me they don't do capacity assessments, but certainly have presented them to the courts in England, and this is what they get back. Who's anybody on this? Right. This was social work. Many people in social work tell me, oh no, we're never involved in that, but experienced specialist social workers have been involved in submitting very major reports in the English courts for some time now, and they carry a significant standing. But they are regarded as somewhat risk-averse, doctors as paternalistic. Again, apologise, it's almost, if not completely, unreadable. Its aspirations were, this particular one was to try to give General Hospital colleagues something to go through and check and consider what might be part of a capacity assessment, and if some part of it appeared particularly difficult or some part of it appeared particularly obscure, we could then, the hope was that reading it would generate enough information to carry the assessment forward, but if not, we could then use the same headings to ask folk to supply a bit of information as to what was causing the major concerns, and that would then be the basis for a referral and for a second opinion. Because it was a newish idea, we generated a similar information sheet for those doing the assessments, as we tried to make those more multidisciplinary, more team-based, and essentially similar headings, trying, as I say, to help ourselves to respond meaningfully. And then a response sheet in which we attempt to identify the areas that either were flagged up as concerns or where we think we have something useful to say. It was never really used to a huge extent. It coincided to some extent first with Andy changing posts and then with me retiring. So it's around if anybody ever found it useful. This is a particularly common example clinically, I would believe, in which someone comes in with delirium. They either have or are subsequently found to have a degree of underlying dementia, so that the good recovery from the care they receive is still constrained by the underlying pathology, and although they may actually get back to better than where they started, there are still unrealistic aspects to what they want in terms of usually going home. Often it's a reluctance to accept care. So we have this difficulty that objectively the person is perhaps better off than before they ever came in, but a certain degree of risk perception has kicked in. And again, we have to try to think our way through. How much capacity do they retain? How realistic are they being? And usually in practice, it's what's their perception of risk. I suspect most of us can live with someone who is struggling but acknowledges risk and, more crucially, acknowledges a need for assistance and a willingness to accept assistance. So sometimes, again, it's what exactly is the required decision. Is it about going home? Is it about going home with care? Or is it about entering a care facility? And again, where should this best be made? I doubt there are many general hospital staff who would opine that this is the best place after an acute illness to decide where to spend the rest of your life. But obviously even a trial discharge with support, if this person will take it, carries a degree of risk. But I would certainly hope that that's always foremost in our minds. There's been quite a nice paper on this. It's in a Psychiatry CPD journal, but it's accessible enough via Athens. And that's about the first time I've seen someone try to go through what I think may be the way ahead, which is almost using worked examples for particular clinical scenarios. Julian Hughes is an old age psychiatrist and honorary philosopher, would you believe, in the north of England, but he has written a lot and very impressively on dementia in general. So they emphasise the centrality of relevant information, and they suggest some interesting topics, as well as emphasising the importance that all of us put on home and the importance that courts put on the notion of home. So they're interested to try to clarify if the person knows why a change of residence has been proposed. The bit I was saying before, do they know what exactly has been recommended? Because often the care home discussion has only arisen because they've instantly dismissed the care at home. The idea of options, does the person really get what the options are, and can they grasp that each option carries potential consequences? So it's still quite a broad framework, but I felt it was a useful approach to quite a difficult problem. A few things, just to begin to wind down. Delirium, clearly bread and butter, clearly difficult in terms of if someone with delirium is fluctuating, their capacity is going to fluctuate. If they are resisting, it is uncertain what best the legislation is to try to treat both the resistance on the one hand and the crucial underlying medical condition on the other. So I'm just flagging it up as an area of particular difficulty that I've neglected to some extent today. Right to treat. I'll come back to it. It's an interesting document from the Mental Welfare Commission. Welfare guardianship, I mention only, to repeat the blindingly obvious, that if we don't have robust procedures, we waste an unbelievable number of bed days. Even if we do have robust procedures, the legal status of someone in hospital awaiting guardianship for whom it is not truthful to say hospital's a necessary environment is unclear. If they start demanding to leave, it is quite tricky. If someone's in hospital, needs to be in hospital, there's legislation that can be brought to bear. But when it is utterly clear that they don't need to be there, and the only reason they're there is the nonsense of waiting for a welfare guardianship, that's really quite tricky. Deprivation of liberty, or a Scottish take on it, we'll come back to. And one of my favourites is in some draft discussion papers. I don't know if this has disappeared yet, I'm not aware of it. There is a proposal to give legal sanction to prescribing medication for wandering. Now, I know in desperation that sometimes happens, but it's interesting to say that that could actually be imposed on the patient with no other legislation than whatever is coming for deprivation of liberty. I think it's safe to say you can look from the first page of the BNF to the last, and you will not find licensed medication for the treatment of wandering. So it's an interesting one to find its way into a quasi-legal context. Right to treat. This is very pragmatic. The subtitle of this document is Delivering Physical Health Care to People Who Lack Capacity and Refuse or Resist Treatment. The first 4 questions essentially reiterate that title, but perhaps are useful to demonstrate that you have worked your way through an approved sequence of consideration in a setting which is potentially very contentious. The slightly disappointing thing is that when you get to the 5th question, doubt still remains as to exactly how much force and exactly which parts of a number of different strands of legislation should be used. But I think the Commission's advice is helpful in the sense that if we all genuinely go through, answer these questions, show perhaps that we've paid attention to this document, we've made an educated guess as to the best legislation, and, if time permits, it is certainly reasonable in cases of extreme doubt to consult with a sheriff. I think we're fortunate in this country. Sheriffs, by and large, are very knowledgeable, very pragmatic, and usually very helpful with difficulties such as this. But it's just to say the Commission thing is useful, but sadly not absolutely definitive. The notion of significant restriction of liberty is a Scottish Law Commission term to try to make decisions easier than the all-or-nothing one on whether someone is suffering complete deprivation of liberty. So they're trying to introduce something in which it's a little easier to come to the conclusion that certain circumstances are restricting someone's liberty. So the Scottish Law Commission consulted in 2012. They produced a paper and indeed a draft bill in 2014. The Law Commission, the England and Wales version, also produced a consultation, this time in 2015. The Scottish Government, unusually, consulted on the Law Commission's findings in 2015 and then went silent. I'm not aware of any clear-cut follow-up to this. The reason for mentioning it is the Law Commission in England have now got to the stage where the Scottish Law Commission was in 2014. They have submitted to the UK Parliament their report and draft bill. What its prospects of seeing the light of day are in this Brexit-dominated environment, I don't know, but it's around, it's important. The interim legislation in England called DOLS is very cumbersome, very expensive, and in Scotland there isn't really an equivalent. So this is certainly legally a very real issue But whether anything will come of it in the next wee while, pardon me, I honestly couldn't say. So to sum up, my contention is that the assessment of mental capacity is almost everybody's business, particularly in the general hospital, where it's likely to be a real issue. I think that continuous care rather than one-off decisions and the overall issue of residents' capacity are of particular relevance, again, in the general hospital setting. And I'm suggesting that support from old age psychiatry is perhaps best targeted at those situations in which the treating multidisciplinary team has identified difficulties, rather than some sense that there should be capacity referrals in certain broad areas. Thank you very much for your attention. Cheers. So I'm happy to attempt to take questions if anybody does have questions. And I think there's mics. I don't know if they're... I think then it just remains for me to thank you all for turning up, for your attention. I hope some of it was of interest, perhaps tiny bits of it of potential use, but thank you very much. Cheers for now.
Hello. Sorry, my name's Ashley. I'm a bit adverse to asking questions.
I have no idea if you record all this, so I'm just switching it on.
No, that's all right. This is particularly poignant because I'm actually covering for a colleague of mine with a patient that's in with Alzheimer's, but also delirium, and has a power of attorney, has not actually been activated, I believe, for welfare, but that power of attorney, of course, has been doing plus taking care of this person, and has all sorts of stories about issues with safety, and that no one's actually declared the person to be incompetent. Sounds very unsafe at home, and so now, of course, they're saying, well, she needs 24-hour care. The patient says she doesn't want it, but there is an aspect of delirium. And so I'm just thinking, is it necessary to wait to see if there's an improvement of the delirium before you can actually get a bead on whether or not you can say there's capacity?
I think it
just seems really sticky.
Well, you're right, but I think the issue is there will be decisions you have to take in relation to the delirium. Where the person stays is possibly not a decision that has to be taken while they're still actively delirious. Does that make sense?
It doesn't, in a sense.
I know that delirium can drag on for
Right.
a long time, which is that's a big
Yeah.
issue, but the conventional wisdom would be that the delirium should be allowed to
See if it, at least
receive
give it a
as
chance
much
to
as
see if it'll
possible,
improve.
then the baseline assessment, and then any associated capacity.
Right. I fear that's where we are because, unfortunately, the power of attorney is fed up, and has said, if she goes home at all, she quits. She says, I'm not going to do it anymore. And so you're thinking, how long has she been off? And no one's given her
Yes. That's sadly the case.
Yeah.
No, there's no, the point I was trying to make is there's no easy answers to these things.
It would be so nice for, but it's
There's
just really tricky.
There's nothing tougher than delirium because of the fluctuation and because it adds obviously to the underlying.
And this is absolutely the conversation we're having is we need someone that can assess whether or not she has capacity. And then whatever the slides you have kind of resonated with me that actually there needs to be an initial assessment before you can ask for a second opinion. Well, it's just like sort of trying to put it off on anyone else to say that they
It doesn't always happen.
Yeah.
I object strongly, or I always used to object strongly to the sense of a first opinion, because I'm not going to be the one responsible for implementing it. Whereas if someone says, look, this is what we think, only marginally, and these are the difficulties, and can you assist in any way? That's easy.
Yeah.
You know, you're saying, I agree with you, or I disagree with
Right.
you, I've got this suggestion, or sorry, I'm lost. And usually it does come down to that. And we are stuck for a while until the delirium.
Because that's
picks
what I
up
thought.
a
It's
bit.
not fair to ask someone else to weigh in when I'm well aware that there are things that are causing things to fluctuate right now
Sure.
that no one can see through unless they have
Yeah.
some sort of magical ability that none of us have. Well, I appreciate your talk.
No,
Thank you very much.
you're welcome. Obviously, we're kind of modest in our numbers, and
Well, that's why I said it's
I think
unfortunate because
psychiatry is sort of stranger to the general hospital. But
no.
the topic isn't a stranger.
No,
we
no,
are.
it's not. It's not. And unfortunately, I mentioned to our FYs, I said it would be an excellent topic if you could come, but unfortunately, they've gotten so swamped today that there was no way to get away.
Yeah. No,
so
I
I appreciate
I
your
know
talk.
that last week there was a reasonable, a respectable audience, not a big audience, from that line talking on the case talks, and it was fantastic.
And we did a great job.
It was also, I would have thought, absolutely bread and butter stuff.
Sometimes I can't predict why, because some things I'm thinking, why are there so many people here? Because this is I try to come whenever I can, or even when I can't, and I'm thinking, I've thought for sure today would have had lots more here. But I appreciate your time.
No,
Thank you very much.
you're very good. Cheers.
Wait, because if I transfer